Hello, and welcome to the 2021 Society of Breast Imaging Summer Webinar Series. Thank you for joining us either via Facebook or YouTube. We're excited for this upcoming series. I'm Dr. Matt Miller. I am practicing in Pittsburgh, Pennsylvania at Allegheny Health Network. With me, I have some fantastic expert panelists that we can dive into some topics today. So first, before we get into it, I'd like to go around and have each panelist introduce themselves. I guess we'll start with Nina.
Hi, I'm Nina Venkoff. I'm the Chief of Breast Imaging at Northwell Health in New York. And also within our department, I'm actually also the Vice Chair for Patient Experience in Radiology. And it's great to be here, Matt. Thank you so much for organizing this again. We had so much fun doing this last summer. Really excited to be here again.
Absolutely. It's great to have you. We can just kind of go around. Whoever wants to introduce themselves next can.
I can go. My name is Jean Kunjiman. I'm the director of the breast imaging at the Midtown campus at the Emory. And we looking forward again to have a lively discussion. I did have a lot of fun last year discussing various topics with Matt and Nina.
Great. Who's next?
I'm Pauline Germain. I'm the Vice Chair of Research and Education at Cooper University Hospital in Camden, New Jersey, and I do breast and body imaging, and I'm excited to talk to all of you about these COVID lymph nodes that are killing us at work. So can't wait to hear what you have to say.
Thanks.
I'll be next. I'm Linda Larson from University of Southern California in Los Angeles, California. It's my first year here, so I'm very excited to be here. I'm the Chief of Breast Imaging at USC, as well as Vice Chair for Professional Development. So thank you for including me.
Absolutely. Last but not least.
It's just me left. I'm Kaita Dados, and it's a pleasure being here tonight for most of you guys, timing-wise. I am a breast imager and associate professor of radiology at Weill Cornell. I'm a site leader for one of our new Weill Cornell breast imaging sites and the associate program director for our residency. And it's been certainly a very exciting year this past year, so I'm very excited to join this discussion tonight.
Absolutely. Well, I thank you all for being here, agreeing to join this discussion. As you, the viewer, can see, we have a wide range of geographical representation here, and I think that that's a theme that will continue throughout this summer series. Just before we kind of get into the COVID-related stuff, just wanted to kind of introduce the summer series again and kind of go over what we have changed from last year. This is, if you're not familiar, if this is your first time, it's an informal webinar series. It's meant to be kind of a roundtable discussion where as if we were all sitting around the table talking about a given topic. They're meant to last about an hour, give or take a couple of minutes. And, you know, we did this last year and had great success. We had thousands of viewers each week on Facebook and YouTube. We had some great interactions with people. And we took a lot of the comments that we received from last year's webinar series, and we look to improve it this year. So last year, it was started kind of as a response to COVID in getting a, kind of education out there to people about, the growing pandemic and how our response in breast imaging is being formed. And it kind of snowballed from there into kind of a generalized educational webinar series. And so it's kind of, I don't want to say it's put together haphazardly, but, it was definitely expedited. The process was expedited. This year we have a little bit more of a thought. We took the comments that we received from last year and kind of wove them into the fabric of this series. There are topics that were recommended from viewers. We included those, and there's kind of more of an ebb and flow week to week type of thing. We also included target audiences. So if you look at the schedule, which is listed on the SBI Facebook page or SBI Twitter page or Instagram, it's pinned on my Twitter page. So if you look at the schedule, there's a target audience. So there's definitely something for everybody in this summer series. Last year we had 9 webinars. This year we have 7. There's a different moderator for each webinar. And as you see, there's 7. There's 1 moderator and 6 panelists today. And we'll get to you. Hi, Jill. And last year, we would have 3 or 4 per webinar. This year, most of them, I think the lowest we have is 4, but most of them have, 6 and greater. And that's great. So that there's more voices, there's more buy-in from experts across the country. We're excited about that. Last year we did it on Mondays. This year we changed the date and time. It's going to be every Wednesday at 7 p.m. except one. And you can see that on the schedule. I'm blanking on the date of it, but start at 7 p.m. Eastern time to give our friends on the West Coast some time to get access to the series. They will be recorded again, so they will be available within 24 hours on the SBI YouTube and Facebook pages. So it's great if you watch it live and you can interact and ask questions on Facebook that can hopefully be brought up during these webinars live. But if you can't get there, if you want to go back and watch it later, you can watch one of the recordings. So that being said, that's kind of my introduction and reintroduction to the summer series. I'd like to welcome Jill. If you want to introduce yourself, it's great to have you.
Thank you so much. Somehow I stuck backstage. Have some problem entering the room. My name is Jill. I'm a breast imaging fellow at the University of Pennsylvania. I'm going to start my first job at Einstein post-training. So very nice to be part of this group.
Congratulations.
Thank you.
We're excited to have Jill back. Okay, so let's get into kind of the meat and potatoes of our talk today. And the main topic is COVID. So before we get into specific questions and discussions like that, I'd like to just kind of open it up to the panelists to discuss, last summer we were talking about COVID and how it kind of where we were before COVID, what happened in response to COVID immediately, and then where it's transitioned to where we are today, with the rollout of the vaccine and whatnot. So does anybody have any opening comments about that?
Sure, I'm happy to jump in. Obviously now that we've been able to maybe breathe a tiny little bit and look back at what happened last year and gather some of that information, it's been evident that there was an acute impact on COVID-19 on breast imaging practices during last summer, spring and summer, with the majority of practices experiencing at least 80 to 100% volume decrease, all breast imaging volume, and the majority or more than half of practices actually closing at least one site. And across the board, regardless of the fact that, me and Nina and some of us are more in the Northeast, and that was certainly sort of the first and the primary epicenter, regardless of geographic variance, because of the recommendations and sort of in an effort to conserve some of our, at the time, PPEs and also to decrease the spread of vaccine or the spread, of COVID-19. Certainly, there was a uniform decrease in screening mammography, which is a very important topic certainly to touch on, with 94% of practices decreasing screening mammography almost to zero at that time. Since then, however, in particular, since last fall, in particular with the rollout of vaccines, breast practices across the country have worked really hard to get patients back in, institute a lot of safety measures, which we can certainly touch on, and are now seeing, and I can speak personally, at least as far as Weill Cornell, are seeing screening volumes of patients, screening patients that are higher than pre-pandemic volumes in an attempt to accommodate and really make up for the time lost. So it's been sort of a roller coaster of experience that we're certainly definitely in the recovery stage so far.
And I would like to echo what Katya said in terms of the volume. We certainly had a dip in the beginning of the year, a tremendous dip, something none of us anticipated. And then we've been on the uprise to the point that I know in our institution, we're on the record productivity in the first quarter of 2021. And I think the rise continues because people are definitely coming in since the start of the pandemic now. And people feel comfortable coming in.
Yeah, I agree. I was really worried last summer. I'm here in New York, and like pretty much everybody else, we closed down for 2 months. We were closed for the entire months, from the middle of March till the middle of May. And if you had spoken to me last summer, I was convinced we were going to be down 25 to 30% for the year, if not more than that. But that actually didn't end up being the case. We opened back up and people came back, and I think we did the right things to make people feel safe and to make them feel comfortable in our offices. And so for us, at least at Northwell Health, when I looked at the end of our volumes for 2020 and compared them to 2019, we were only down by about 12%. And now if you look in the past 6 months, in the first 6 months of 2021, we're way over what our normal volumes are. We've more than caught up. But it's not insignificant. Like I looked at last year, we would normally do in our health system 87,000 screening mammograms a year. So in 2020, we did 77,000. Which doesn't sound so bad, except it's 10,000 people, which means it's 50 cancers probably that were not picked up on screening mammography last year. So while not as terrible as I thought it was going to be, still important.
It's not insignificant, yeah.
Well, we had a similar experience. We at USC have a private facility and a county facility. And there was clear disparity in care. Like we shut down, and our administrators in the hospitals didn't really pay attention to radiology. They were worried about surgery and medicine, so we pretty much called the shots. So we did shut down screening in all facilities from March till June. But in June of 2020, we picked right back up on the private facilities because we had the PPEs. We'd COVID test each patient before we biopsied them. It was so safe. But at county is where our real problems were, because we didn't have anything except a questionnaire when the patient walked in. So there was no temperature check, there was absolutely no COVID test, nothing. So it was much harder for us to take care of these patients. So we still aren't back up to capacity at screenings. We shut down screenings until 50% starting in July. The second surge in December, we shut down again. So we're behind thousands of screenings at our county facility. So obviously they're looking for ways to get that back up. But as far as the private side, we had the ability to bring back all those patients, and I think we're at 100%. We're not over, but it's the county problem that's hard for us.
Yeah, I also wonder,
has anybody experienced, and we kind of experienced this, kind of surprising, but then it made sense kind of in retrospect. So, we were getting, once we opened everything back up in Pittsburgh, in the late fall into winter, we definitely had that surge of mammography, from October to December, with the stereotypical every year, the insurance rolls over, right? Into January, our volumes were still kind of picking up, and then January, February, and then we actually had a little bit of a dip starting in late March into April, and it was like, well, it was kind of we could kind of see it. The dip was actually real, and then it picked back up in May, and it's back to above where it was, and it kind of was surprising. But then looking back, it shouldn't have been, because we were closed for a month and a half, and all those people that would be getting letters weren't getting letters because they were pushed back. Did anybody else experience that?
Yeah.
We did at Emory too. So we were closed last year from middle of March to almost middle of June. So we definitely see from April to May, there's a dip in the screening because it's an insurance thing. So those people there have to wait 365 days for the next screening exam to get reimbursed. So you just see, because of that shutdown, that 2 months, that there's a dip. So I figured probably the middle of June, it will start picking up, because it would be 1 year when we started opening it up.
Yeah, we also noticed that. Go ahead.
No.
Go ahead.
I just want to say, at Penn, we also noticed that we started to have some people who never had screening at Penn, but now it's coming in. Our volume is way over, above our baseline, actually, for several months. And then I think some people maybe from other hospital cannot get appointment. So they probably kind of like right now switching facilities. And just take my mother-in-law, for example, she was trying to go to the same facility she has been going for years, and her appointment was scheduled like four months out. So I think some patients actually coming to different facilities just to get an early appointment. We end up having to request much more prior films as we did before.
I'm
You were
curious.
something, Pauline?
The dip that we experienced, a small dip we experienced, was related to the national news, because it made it to the national news and everybody was reading the headlines about the COVID vaccine and potential lymphadenopathy. And I know myself, I was getting a ton of texts and calls regarding postponement. And I think that perhaps led to some of the delays in that late spring.
So that's a great segue. Go ahead. If someone else has something to talk about, we definitely need to get into talking about vaccines. But go ahead, whoever was talking.
I was just saying I completely agree, Pauline, when Matt started talking about the dip, and it made sense from sort of, those patients missed it last year and so didn't get letters and reminders and so on. But the most sort of stark and I feel like remarkable event that happened over March is the realization that increased sort of prevalence of COVID-19 related reactive benign transient adenopathy, and then the recommendations that were issued alongside it. And so I think that created a lot of hesitancy. And so a lot of our patients all of a sudden, again, were concerned about coming in while they were reassured in the fall with the safety measures that we institute.
So let's jump into that. Let's talk about COVID vaccines and kind of breast imaging, dealing with them. So I'll speak from the standpoint of a patient. So as a patient, say I get a COVID vaccine, should I delay my screening mammogram? Say I get a COVID vaccine this week, and I have a screening mammogram scheduled for next week. Should I delay that? Should I call my breast center and delay that?
Absolutely not.
I'm actually almost thinking like if it's only a week, maybe you should do the mammogram before you get the COVID vaccine, just to get it out of the way. Since our volume actually picked up a lot because of those lymphadenopathies. We are one of the center that first published regarding this lymphadenopathy on our high-risk screening MRI patient. These are a little bit tricky group because they're high risk, and when you see unilateral lymphadenopathy, you want to be more careful regarding the and we also have a very high volume, high risk MRI screening, so we end up like have a lot of ultrasound of the axilla. So that make us even more backed up with the increased volume of screening and also increased diagnostic workup. So initially we have the patient come back right away and then do a baseline ultrasound and then have them come back in 6 to 8 weeks. Some patients the size of the lymph nodes goes down, but some patients still a little bit enlarged, as some papers have indicated that. So now we actually started to, based on your more research and more evidence has been suggesting it can be safe to let those patients go sometimes if they are not symptomatic. And so sometimes right now we just have them come back in 6 to 8 weeks for that follow-up ultrasound.
You're talking about patients that already have the adenopathy. And
they already had an adenopathy, okay. Yeah.
Okay. So thank you for that. So kind of backing up a little bit, dealing with more of the before you get called back. So, yes, we can get into how we kind of deal with lymph nodes and vaccine related reactive adenopathy or whatnot. But before we even get there, there's kind of a discussion to be had about what we should do in response to, okay, vaccine, mammogram scheduled kind of almost simultaneously or within the same time frame. How should a patient handle that? How have we been handling that as breast imagers?
I think that's a great question, Matt, and it's a lot to unpack in particular for our patients, which is, I think, the challenge here.
Yeah.
And certainly, when we can start touching base a little bit more on the sort of repercussions, but the bottom line is that screening mammography and COVID-19 vaccines are very important to women's health. Get both. You need to get both. And the timing of the two is really anymore not that important, right? I mean, I think we have to remember that in particular with regard to what we touched upon earlier, is that with the increasing volumes, with all of those missed appointments that we've had over last spring and summer, a lot of the facilities don't have the capacity to try to have the flexibility of scheduling. And also remember, from our patient perspectives, who are similarly inundated with all of the incredible stresses and financial burdens of the past year and a half, they may also not have the flexibility to reschedule their mammogram around their COVID-19 vaccine. So I think, we can talk about timing, we can talk about weeks before and weeks after, but I think the bottom line is get both whenever you can. And if there's flexibility, we can talk more about that. But otherwise, just get them. Get them when you can.
Absolutely.
Yeah, I
completely agree with Kata. Absolutely. Do not delay. As breast imagers, it is our job to figure out what's right and wrong, if there is an abnormality or not. As it is, a lot of the women are already delayed by at least 6 months, if not a year, due to pandemic. So complicating the issues and adding further delays is absolutely not in our favor. And that is certainly added to all the other health issues and disparities. So absolutely do not delay your mammogram.
Yeah, I have definitely felt like this has been sort of a public health disaster, to be honest. I feel like the messaging has been really confusing to women. I constantly have to explain to patients that the COVID vaccine doesn't cause breast cancer and doesn't look like breast cancer in your breast. I mean, the media loves jumping on stuff like this, and I really found the entire situation so upsetting that two things, as we've all said, that are so important for women's health, right? Getting your vaccine so that you don't get COVID and having your mammogram got combined in a way that made people afraid to do both.
Yeah, it's not either or. If I had hair, I'd pull it out, because I mean it's
horrible.
Yeah, it's
from a
crazy.
public health point of view, it's a disaster. And I don't know about the rest of you, but I'd like to know, is there anybody here that hasn't been dealing with flu vaccine and lymphadenopathy like forever? Like, we always have seen this. This is not something new. Like, yes, the COVID vaccine causes sort of a whopping immune response and more lymphadenopathy than you see with flu. But we were always seeing with flu vaccine lymphadenopathy, and we always knew how to deal with it. So I've been really disappointed by the way this has been handled, and I have really tried to downplay the messaging. As the person who gets to be in charge of the messaging in our health system, I basically have said from the beginning, don't delay, come in for your mammogram as scheduled. And if we see something, we're doctors, we know how to handle that, and we will advise you about what to do next should that happen. You don't need to worry about that. Come in and have your mammogram. That's been my message from the beginning.
Yeah, I agree. Echoing what Katya, Nina, and Pauline said. Only thing is, like, if I usually tell all our breast surgeons and the breast oncologists for their patients, like if they have a history of breast cancer, to try to get it in the opposite breast if possible. So even if they come for mammography, if you see lymphadenopathy, it is related to the vaccine and not like recurrence from that same side from that same side.
I think also to add to that, if after you get COVID vaccine, you have symptoms, don't just assume it's because of COVID vaccine. Do come in to get your checkup. We have a patient who, felt a really big lump in her armpit after the COVID vaccine, and she got in. It's actually lymphoma. Probably has been there for a while. Maybe just after COVID vaccine, she started to have pain and feel it a little bit more. And coming, we diagnosed her. Otherwise, she could still be delayed. And we also have seen lobular cancer. That probably because the patient started to feel the area more after COVID vaccine. So I think we also have to get message across. Don't assume everything's because of COVID vaccine. If you have symptoms, you feel something, do come in.
Yeah. And I think that's a good segue, unless other people had other things to talk about. So we talked about, timing wise with the vaccine and screening and whatnot. Let's talk kind of going further into it. We talked about the lymphadenopathy. There is a lot of misconception out there that, I'm getting called back on my screener. I had the COVID vaccine. I heard on news station X that COVID vaccines can cause me to be called back. I'm just going to postpone that. I don't want the hassle. I don't want to have to go in. I don't want to be, deal with that at all. It's probably just for my vaccine. That's incorrect. That's an incorrect assumption. What are some things, that you can expect? So it's kind of a difficult question to ask, but what are some sequelae? We know about the lymphadenopathy. That's the big one. As far as when you get your screening mammogram, you get called back, can a COVID vaccine cause a mass in your breast? And that's kind of a dumb question, but it's a question that needs to be answered because, if you get called, you see asymmetry on your asymmetry or mass or calcifications, that's not from the vaccine, right?
Yeah.
I think that's a great question, Matt. And I mean, that goes to what Nina mentioned, and it's about the messaging, right? Is that COVID-19 vaccine does not cause breast cancer. It's not mistaken for cancer, which is besides the point. And by the way, and that's the other sort of flip side of it too, the reactive adenopathy is also not a bad and dangerous thing. It's actually your body doing exactly what it's supposed to do. And you are mounting an immune response and creating antibodies and that are going to help protect you in the future. Similar to the flu vaccine, somebody mentioned in the audience that they haven't seen it. We certainly have, by the way, shingles also in older adults. HPV, which we see infrequently because that tends to be in younger patients, and BCG in the rest of the world. So that certainly happens. It's your body doing what it's supposed to do in reaction to the vaccine. But to your question about callback, absolutely, if a woman is getting called back, absolutely don't assume that it has to do with the COVID-19 vaccine, even though that is certainly in the media right now and certainly all anybody hears about. And I think it goes back to sort of the basics of mammography. The reason that we screen women is so that we can catch cancer when it's small and before it is at a higher stage or a bigger size, so that we can treat it, and thus a woman would have a better prognosis and also less invasive treatment. To do that, sometimes when we have a screening mammogram, we look at, we need additional pictures, additional evaluation of certain findings. The majority of these callbacks, so going back, 10% of women in general get called back for further evaluation. That may have nothing to do, in majority of the time, I would say proportionally from a numbers perspective, even in the setting of COVID-19, has nothing to do with your lymph nodes or with your axilla, but rather with something that we see in the breast. Most of those callbacks actually end up being benign and a woman is reassured, but we are satisfied with all of the workup that we have done. And a minority of those then get diagnosed with in early stage cancer, which is most of the screen detected cancers, and then a woman gets treated and has a better prognosis. So delaying that or blowing that off and assuming that that has something to do with COVID-19 vaccine is erroneous and actually defeats the purpose of screening mammography. And remembering also that how common breast cancer is around the world, certainly in the United States. A recent study actually demonstrated that around the world now has superseded lung cancer as the primary diagnosis. I think they were counting skin. And so 1 in 8 women will be diagnosed with breast cancer. And so you want to catch it, diagnose it when it's small, when it's tiny, so you can treat it and move on with your life. And as such, you need to come back for the callback, because that is what screening mammography is for.
I love the stats that you're throwing out because I'm a big stats guy. And I mean, it's important to keep those statistics. COVID doesn't change those statistics. The 10% callback, people get called back, the 1 in 8 women getting breast cancer. COVID doesn't change any of that. COVID doesn't increase or decrease any of that. So statistics are what they are. They were before COVID, they are after COVID. Sure, there might be a cohort of people that get called back because they have lymphadenopathy, but we deal with it. The vast majority of those patients do not have any type of breast cancer, any type of metastatic disease. But it's still important to not ignore that. It's still important to come back, get it evaluated, to make sure that that we're doing the appropriate workup. We've been dealing, like Nina said, we've been dealing with lymph nodes since the dawn of vaccines, right? I mean, I get every year I get a lymph node right here from my flu shot. It's my little buddy, my little angel sits on my shoulder for about a month. So I mean, it's.
I think what it comes down to, what it came down to me when I listened to how this was first covered in the media, is playing into the fears that are always played up in the media when it comes to mammography, right? That somehow our recall rate is a bad thing. That if you were to get recalled for further evaluation on mammography, that's a bad thing. When actually mammography is a screening test that's intended to be overly sensitive, and it's intended to call back 10% of the people that come in. And so they harp on the part of mammography that's actually an accepted part of mammography as a screening exam, and try to play that into a negative aspect of the exam. If we didn't call anybody back, we wouldn't find any cancers. So that's, we need to call back a certain percentage of people so that we can find cancer. That's how mammography works. It's been really hard. And can we just talk about the COVID vaccine part of it? Because we're in a health crisis that basically the messaging suddenly became, not only don't have your mammogram, but maybe put off having your COVID vaccine. And I think in terms of the urgency of the situation, that might actually be the bigger problem. You were much more likely this past year to become acutely ill and even possibly die from COVID than you were from breast cancer. And so the idea that we would tell people to avoid doing either one, I just found just so disappointing from a public health point of view.
No, that's absolutely ridiculous. Absolutely ridiculous.
And just
that's such a good point. Yeah.
Just to continue, Nina, with what you were saying, we're well equipped to deal with all of this. And as a response to our capabilities and our abilities, we've incorporated, and I'm just trying to address the question from the audience, we've incorporated into our questionnaires, into our routine questionnaires, the question about the vaccine, so that we're aware of what our patients are getting. So we know which side they're getting it on, and we recognize that they've had the vaccine based on the appearance of their lymph nodes. So we're proactive. We're responding to what's going on around us, and we're absolutely addressing this along with our patients who are getting their studies, who are coming in and making sure that they're well.
Yeah, I think these are very important message to cross because we do have patients, especially those we give barrier 3, and the patients to come back in 6 months. And those patients will ask, oh, I have my COVID vaccine scheduled. Should I delay it? And our answer is always absolutely not. You should get your COVID vaccine. So here we're talking about mammogram, but we want to make sure everyone get their COVID vaccine as well. And also, we want to make sure you keep track of which side you get it. Some patients may actually get a little bit confused. I got it, but I don't know which side. And I get my first dose on one side, a second dose on the other side. I think one thing you can help your doctor is to bring in your record. Make sure you remember on which day you have it on which side. And then that can help us too.
And just to quickly address the question from the audience regarding testing prior to procedures, we in our facility, we do not test. We do not test. We no longer even check the temperature at the entry into the facility. We assume that people follow safe procedures and safe distancing. And if they're coming in, they must be feeling well and or vaccinated, and they're ready to do what needs to be done for their health.
Yeah, same. So thank you, Pauline. You're making my job easy. I was looking for an entry point to segue into that question, because that's a great question. We're doing the same thing. We're not COVID testing anybody that comes in. We're not temperature checking. At this point, it's been over a year. We would hope that you have the ability to know when you feel ill and not see people in public places when you feel ill. And we're still doing universal masking. I think pretty much every healthcare facility around the country, even though the CDC lightened their stance on it, still healthcare facilities are maintaining masking. And I can't speak for every healthcare facility, but I anticipate ours for the foreseeable future continuing to mask, because I haven't had a cold in a year and a half. I mean, so you get it. That's a whole nother topic of masking. But does anybody want to speak to that question about prior to getting your mammogram, are we COVID testing or whatnot?
We did COVID test prior to biopsies, and we stopped once a patient got vaccinated. We don't test anybody anymore.
Okay.
So I worked in both New York and Pennsylvania during just because I started my fellowship July the 1st last year. So in New York, we tested the biopsy patient only. In Pennsylvania, Philadelphia specifically, we didn't test any of the biopsy patient. Basically, we do a questionnaire screening. That's it.
Okay. Good.
At Emory, we didn't test any of the patients either, any of the breast imaging patients.
We never did either.
Yeah. We never did either. You know, one of the things that we did in our health system was I have a patient and family advisory council within radiology, and we used them last summer to really guide what our processes were going to be, both in breast imaging and in radiology across the board. And we were temperature checking. I think we might still be, but I feel like it's just COVID theater, and that's okay. You can do COVID theater if that's what's going to make people feel more comfortable. And some things that we put in were, quite honestly, kind of COVID theater, like things that make people feel safe, but probably are not really on a scientific level making you any more safe than without. And I'm totally willing to do things that are easy, that make people feel safe. If you want to, wipe down your chair, even though I know you're not going to catch COVID from your chair, that's fine. If you want to have your temperature checked. But I think putting people through testing is a whole nother level of COVID theater that I was just never willing to go to. That just seemed like a step too far, and we never did it for anything.
Yeah, we did temperature checks kind of through the summer, and I don't know when that stopped, but we're no longer doing that anymore. From what I can tell, we have a lot of breast centers, but I don't think we're doing any temperature checks anymore. We never tested. Okay.
I love how we're introducing new terms. We're COVID theater, COVID fatigue, COVID lymph node fatigue. I think we're creating our own dictionary here.
Mm-hmm. Just kind of, we got kind of off on a tangent about, answering the question or whatnot and talking about what breast centers are doing in response to COVID. I do want to kind of tie a bow up on the lymph node topic, because I do think it's an important thing. Patient comes back and now this is a clinical scenario. I'm associate residency program director, so I'm always talking like this to my residents that I work with. But patient comes back and has lymphadenopathy on the screener that they found. They're not feeling it, but they saw a unilateral lymphadenopathy on the screening mammogram. Patient comes back, well, I got my COVID shot there last month. Okay, that's great. Can we adequately say 100% that is COVID related, benign, see you later? Or what are some methods that we use in response to this clinical in an actual real scenario like this, because it is happening?
That's the easy scenario. The scenario where they feel it, that's the best one. I wish they all felt it, because if they feel it, then what I say to them is, if you're feeling it and it doesn't go away in 3 months, come back.
Yep.
And that's what I put in the report. No follow-up imaging. I just read the mammogram based on the mammogram findings. If the patient is feeling it, I will just say that for adenopathy that doesn't, we assume this adenopathy is related to the COVID vaccine. Yep. For adenopathy that doesn't resolve after 3 months, we can do additional evaluation. And I actually don't give a BI-RAD 3 or a BI-RAD 0. I just read it based on the mammography findings. I love it when they can feel it. It's a little harder when they can't follow it clinically.
Sorry, Nina, I mean to interrupt, but this is the scenario that you're talking about, is if the patient comes in for their screener and answers the questionnaire, I am feeling lymph nodes since my
vaccine. That one.
Yeah. What about the ones that aren't? What about the ones that are just coming and getting their screener a month after they got COVID and they have unilateral lymphadenopathy?
I think that depends. That's a great question. And sorry, I was MIA temporarily, technical difficulties.
We missed you.
Welcome to 2021. But it depends, right? I think for the majority of the cases, we can say, yes, absolutely. And I think going back to what we discussed before, and certainly Pauline mentioned questionnaires, and a lot of practices are instituting it. I think it's important that our patients feel empowered to share this information with their mammographers, with the technologists, so that we know, and it's always helpful for us to have sort of a full picture. So we're not reading your mammogram in a vacuum. We're reading it as part of who you are as a person and every other process that's going on, everything that's happening in your life. So if, in the context of appropriate history, ipsilateral, recent vaccination on a screening mammogram with adenopathy that looks, frankly, reactive, right? As long as the morphology is maintained, there's a little bit of cortical thickening. And obviously, as we always do, which I feel like that messaging also got lost in the media, we always look very carefully at the breast. That is what we do. That is actually our job. That's what we've been trained to do for years, right? So if looking for any signs of breast cancer, if that does not exist in that, certainly in the ipsilateral breast, but in the entirety of the mammogram in the breast tissue, then I think comfortably in the appropriate context, you can call it BI-RADS 2. And basically call it what it is. And that is certainly some of the evolving recommendations that have come out from certain practices, and the American College of Radiology acknowledged that that is a viable option to address a large volume of patients coming in and being seen with COVID-related reactive benign adenopathy. I think the issue becomes when the morphology is altered, and we've seen some of the case reports. We published a few where it looks like a node that has completely obliterated fatty hilum. It doesn't look great. We don't love seeing that. So I think in that case, I think it's very reasonable to follow them up to the expected resolution, or at least decrease in size, not necessarily resolution, in a short period of time with the appropriate history.
Yeah.
So
also,
is everyone adhering to the 4 to 12? So yes, we talked about the BI-RADS 2, if they smooth contour or whatnot, but if you have one that looks kind of abnormal with the fatty hilum displaced and whatnot, and something that you're not feeling too comfortable about, you give it a BI-RADS 3.
BI-RADS 3, 12 weeks. We do a BI-RADS 3, 12 weeks. 12 weeks. Yeah. Is that 8 weeks didn't work because we did that for a little bit, but a lot of them were still enlarged. So we do BI-RADS at 3, 12 weeks. Okay.
But that's only for us. We would only do that if it looked abnormal, like only if the morphology was abnormal. If it's just mild cortical thickening, I'm not recommending any follow-up at all. If it's just ipsilateral on the side of the vaccine, only for those really ugly-looking ones.
Are you talking diagnostic or screening?
Both.
Both. Okay.
I think if the morphology is altered, we actually don't really wait. If the morphology doesn't look good, we just activate it right away. And also we ask detailed histories, like if the patient have family history of breast cancer, if they're high risk, and then if they have prior breast cancer, high risk lesions, those women, we are more careful with them as well. Symptomatic, we actually also tend to evaluate them right away, just in case we miss anything. So.
Okay. So you jumped right to biopsy, Jill?
No. I mean, like if the morphology looks abnormal.
Okay.
Yeah.
Okay. If the morphology looks abnormal, I agree.
Yeah.
Agree.
Absolutely.
And I think we all underwent evolution in our knowledge, at least from the beginning of COVID.
Absolutely.
Now, right? We've all gotten so much more comfortable seeing these lymph nodes, recognizing them, knowing that smooth cortical thickening is now a comfort zone. Now we're okay with it, but in the beginning, it wasn't as comfortable.
A little scary. No, absolutely.
Yeah, I mean, it's so interesting. So in our health system, we actually did the first vaccine in America in our health system, and 3 days later, they started doing all of us. And so actually my associate chief of breast imaging, she and I got it, I think, on like the 4th day that the vaccine was available in America, and she got crazy whopping adenopathy. And it was because of her that we immediately put into our questionnaire, what side did you have your vaccine, before anybody else was doing it, I think, because she had everything. She had supraclavicular. It was crazy. She had cervical nodes. Wow. She probably had the worst that I've seen of anybody in all the months since then.
And it was 2 days in. Well, I mean, so that's a good segue into, when this first started, when they unveiled the vaccine, and I had heard about adenopathy or whatnot, I'm thinking, gosh, this is going to be, we're going to see lymph nodes on like every screener. And to me, it's not like that. To me, I mean, perception versus reality, right? I mean, we see it every once in a while, but I can't, there's not too many times when I call back someone for adenopathy, even with these COVID vaccines. So I do think that, we are, it is happening. It's a real thing. It's a real thing that can happen. It's a real response to the vaccine. It means your body's working. Doesn't mean your body's not working if you don't have adenopathy, but it does mean your body's working. But I think, at least from my personal standpoint, I thought we were going to see it a lot more. Does anyone agree with that?
I definitely agree. There are people who don't have adenopathy. Yeah.
We see quite a bit. I do. I disagree quite a bit. And the reason is many of our patients get a combo of screening mammogram and screening ultrasound. So we actually see them the same day for screening ultrasound. And obviously, as part of screening ultrasound, we check the axilla. So almost every other patient will have cortical thickening between 4 and 6 millimeters. Sure. And you know that it's on the side of the injection.
So best thing I ever did as a breast imager ever was about 2 or 3 years ago. We took the axilla out of our screening breast ultrasound exam before COVID. Best thing I ever did. So we only do the axilla for diagnostic sono. We don't include the axilla, and it's not required for the exam. So we don't include the axilla for our screening sono. Thank goodness, because that has made my life so much easier in this past 6 months.
We don't do the axilla either.
Series, Nina, like topic. I think that should be another SBI Summer Series topic, the axilla and all the controversy surrounding it. So
I like it. Here I am writing it down.
Yeah, we actually do.
Pauline, we are also doing a lot of screening ultrasound. We have a very high risk population also that we're seeing. So that was one of the reasons for it. And so we're seeing a lot more, I would say, in proportion to others. But I think to Matt's point, it's proportional, right? So of the percentage of people that we are seeing for screening, it's a small percentage. But overall, because of the vaccine rollout and the timing to the general population, how many people have gotten it of late, that's a significant number, although proportionally small compared to all of our screens.
So Katya, you guys are doing the axilla on the screening ultrasound as well?
We are.
You are.
So we were doing so many lymph node biopsies when we used to include the axilla in our screen. I felt like I was more of an axilla radiologist than I was a breast.
Axilla Godzilla, huh?
And I finally was like, that's enough. We're done. No more screening the axilla. That's for somebody else to do, but not for breast imaging. So we took it out.
We don't do the axilla either.
Yeah,
my question though is for Pauline and Katya, so when you're saying that you're seeing a lot of lymphadenopathy, are you picking it up on the ultrasound, or are you seeing, because my point was I wasn't seeing it a lot on the screening mammogram only. Like you know what I mean? Like I thought that I was going to see it a lot more than I am. Obviously, if I'm scanning a lot of people's axilla, I'm sure there's thickening.
Yeah, I would say if I see it on the mammogram, I definitely see it on the ultrasound.
Sure.
But there's also a converse where we only see it on the ultrasound because we put the probe down there.
I got you.
Yeah, the minority of the cases are mammographically apparent. So I would say like you like numbers. I would say if I'm guesstimating, 2 out of 10 are mammographically apparent. The rest are all sonar. So that we are definitely paying the price, Nina, for doing our screening ultrasounds with axillary screening. But
we would say about 10% of the screenings that we see have positive mammo nodes.
Yeah, we actually do screening, fast MR for screening, the abbreviated MR protocol. We use that to screen dense breast. So we don't really do screening ultrasound as much. Occasionally we just use the standard, I believe it's ACR protocol, just the 4 quadrant plus the subalveolar area.
We were trying to see if we correlated with age, if more younger women or older women, but we didn't really see anything.
Didn't really see that?
No.
That's interesting, though. That's a good thought.
Yeah.
That's a good thought.
But I would say that from anecdotal experience, we've seen more lymph nodes after the first shot than after the second. They just blossom after the first, and they're kind of cool after the second, just from anecdotal experience.
So at what point, so we've talked about kind of how we deal with vaccine-associated lymphadenopathy, and, it seems like as we go on, more and more people are taking more of a conservative approach and not really worrying too much about it, not giving less and less BI-RADS 3. I mean, I agree. When it first started, I was given a lot of BI-RADS 3s, and then, at what point do you biopsy them? Taking morphology out of the equation, morphology, if they look morphologically abnormal, we biopsy them. So say a colleague who is, gung-ho about following these axillary lymph nodes and recommends a 12-month follow or 12-week follow-up, and it still looks smooth and has that contour or whatnot. Because this has happened to people in our group. Do we biopsy them or do we do another 12-week?
I think it's important to remember one of the things is that, certainly with other reactive adenopathy and in the vaccine trials, which, by the way, we're evaluating lymphadenopathy based on palpation, where it was resolving in a few days to a few weeks, that they were reporting, not on imaging, is that anecdotally, and I'm sure some evidence is forthcoming very shortly, we're seeing that this reactive adenopathy is lasting a lot longer than expected. So the 12 weeks, which was it's coming from the SBI recommendation that was issued very early during sort of the evolution of this phenomena, if you will, in very, very early March. That was the expectation. But we are seeing that they're lasting a lot longer. The immune response is a lot stronger than some of the other vaccines. And so I think that is something that's important to remember. And also, I'm noticing this across, some from some colleagues and institutions where, there's sort of this tendency of like, well, if it hasn't resolved and have gone to become normal, then therefore this is abnormal malignant adenopathy. But that is not the right approach to something that is a process, a reactive process that, smolders down and slowly comes down. So if you're seeing a little bit of a response, that should frankly be sufficient, right? Metastatic lymph nodes are not going to improve on their own. Otherwise, we would all be out of a job, right?
Yep. So that's exactly what I was going to say. If we see anything moving in the right direction, that's enough.
We're done.
Yep.
Moving toward the right direction is good enough.
Yeah.
And also, we also want to, again, assess the patient's history, like if you have breast cancer, high risk lesion, family history, high risk, then our threshold is a little bit, our threshold to biopsy is lower than average risk woman. Also because we also do lots of FNA, it's very minimum invasive.
And I love, and that's the second or third time you brought up history, Jill, and because it is important. I love that you're bringing that into the fold as well. I mean, if someone has, a BRCA mutation or strong family history or even a personal history of breast cancer, we're gonna treat those lymph nodes, at least from my, I don't want to speak for everybody, but from my standpoint, I might be a little bit more aggressive in my treatment of those lymph nodes and making sure that they're normal, even if they, follow, someone else who, doesn't have that history and, if they look the same, I might be a little bit more aggressive in my watchful eye of those lymph nodes with people with a history. Is everyone,
but even with those people, I think you still want to be sending for flow cytometry and immuno, because I think that you're still more trying to rule out lymphoma than you are trying to rule out breast cancer. So I think even in that high risk group, if as we all said, you're doing it because you did breast imaging. So you already have presumably a negative mammogram and a negative ultrasound or maybe a negative MRI. The chances that it's breast cancer is small. And if you're going to bother biopsying it, you should be giving, strong consideration to the fact that it's lymphoma and has nothing to do with breast cancer at all.
Actually, I think that's another great point. So, if it's not go away, do another close look at the breast, because sometimes if the patients are very dense, there is a chance we may not see something hiding on mammogram. An ultrasound is a little bit tech dependent, so MRI can, have a role here.
Would you do an MRI before you biopsy?
I would not.
I think we usually just like if the assessment is BI-RADS 4, then it's BI-RADS 4. We don't really use MR to swing us.
Mm-hmm. But
somebody just wrote a comment that I loved. Gail Starr out there. Gail, I love your comment. She said, 12 weeks is too short. We do a 6-month follow-up and tell patients to return sooner if they can feel it enlarging. I think that's great advice. And actually, after this talk, that's what I'm saying from now on.
I might use that. That's good. I'm glad someone else said that, because I've been having that in my mind.
Thanks, Gail. That's perfect.
Yeah, thank you, Gail. Absolutely. That's a great comment. And I think that we can conclude our kind of, discussion about the lymph node with kind of that sentiment, right? I mean, it's, we were aggressive to start with COVID because we didn't really know how to deal with, not that we didn't know how, we've always known how to deal with lymph nodes, but we thought that it was going to be more than it kind of is. And now we're, these lymph nodes are showing up and are normal looking, and, they might just be a little bit plump. I think that, we can kind of back off now. What were you going to say, Pauline? I'm sorry.
No, I was just going to continue Nina's point, is that if we check the breast, we check the ultrasound, and we see this full lymph node, the risk of breast cancer or metastatic disease from breast cancer is less than 1%, as we know. So really, we have gone above and beyond, and less than 1%, that's really BI-RADS. We're BI-RADS too. We're good here. So I think this is really just proving the point that we're all trying to make here. I think we've all gotten comfortable and we have lymph node fatigue now, so we need to move on.
Absolutely. Well, we're at about the 55-minute mark. Are there any other comments, final thoughts that anybody wants to talk about in responses? I think this was a fantastic discussion. I thank you all.
I think we need to rewrite the guidelines for SBI, incorporating Gail's suggestion.
Yeah, Gail, I like your suggestion. I think we need to incorporate something like that. I think that's much more along the lines of, I think, where all of our comfort zone has gotten to over the course of the past few months.
And then we need to talk about Nina's suggestion about taking out the axilla out of the ACR guidelines. That will
it's not in the ACR guidelines. So
yeah, it is not.
It is not. You don't need to scan the axilla for screening.
Yeah.
For screening breast. It's all 4 quadrants and the retrorealar breast. That's all you have to do.
5 images.
Yeah, that's it. So diagnostic for sure. You know, if someone has a breast cancer or something, then you have to scan the axilla.
Yep.
Screening, no.
I also want to just say, like, we do see lymphadenopathy in other vaccines. Some people come in, they got a shingles vaccine and their lymph nodes is huge. So I want everyone to aware, it's not just COVID vaccine. It can happen with any vaccine, especially the flu season is coming up. People may get flu vaccine, so it applies to all.
Yeah, and I think that my comment would be what we started with. I think the important part is get both. You need both to protect yourself and your loved ones. And the side effects, potential benign transient side effects, will not be mistaken for breast cancer, will not really lead to any, truly shouldn't and won't, unnecessary biopsies, given the fact that we are now learning and the sort of the knowledge gain has evolved so drastically as it has with most of COVID, and how important it is to really return and not and sort of make up for the time lost over the last year in order to get back to sort of saving those lives that breast imaging is about.
Yeah, I think that's really important for everyone to know. This is not one of the reasons you can skip your COVID vaccine. It is so important for us to move on as a nation, for everyone to get vaccinated.
We could honestly now, getting into the social media aspect, we could start a campaign, #GetBoth.
I love that.
Think about that.
#GetBoth.
I love
Absolutely.
I see it coming.
Yep, let's do it.
One of the problems this past year is everybody thinks they're a scientific expert, right? So it's like half the battle of this past year has just been trying to let the real experts have a voice in what policy is going to be. And like first you saw it with COVID vaccine, and now you're seeing it with this. And it's, there's a lot of voices giving people advice about science, about medicine, and they're not all reliable voices. And they're, this is like another example of, I think, how women can be led astray and get convinced to do things that are not in their best interest by the media and by social media. It's scary.
Yeah. I mean, it's like drinking out of a fire hose sometimes. You just got to look at your source. You have to, that's paramount. Before you start going around and putting things down as gospel, it has to be a credible source. It has to be, everyone learns something from other people, but you have to make sure you vet where you learn that stuff at.
Yeah, and also remembering to that point, though, right? During this pandemic, which was, we knew about some COVID variants, but this was certainly a new strain. That information and a lot of the repercussions of the pandemic and of the virus were really new to the scientific field and to our knowledge. So that you needed to give a little bit of time, like you said, not taking things as gospel, to actually build up that evidence so that we can draw valid conclusions. And now we have population-based conclusions that we can draw and safely reassure our patients. And I think we're at a point where we certainly can do that, and definitely for both.
Absolutely. And since the rollout in December, we've gotten enough already information in the initial rollout and follow-up. We have plenty of patients since December that we've seen and feel very comfortable at this point.
Absolutely. All right. Well, I think we're at our hour time slot. Unless anyone has anything else to talk about, I think we can conclude. Again, I want to thank you all for joining us. This was a fantastic discussion that I'll probably watch back because I think that we had some great conclusions that we came up with here today. And I want to thank everybody who watched us, both live and on future recordings. Please join us next week. Same SBI time, same SBI channel for Dr. Larson's moderated discussion about breast fellowship. So look forward to that. Until that time, have a great week, everyone.
Thanks so much, Matt. Great job. Thanks so much, everybody.
Thank you.
Happy summer.
Thank you.
Take care, everyone.
That was awesome, guys. Thank you.
Oh, thanks, Matt.
Thank you. Yeah,
Okay.
sorry I stuck backstage.